I'd like to introduce Dr. Natalia Rodriguez, who's an associate professor of public health and biomedical engineering at Purdue University and a member of the Indiana University Simon Comprehensive Cancer Center. She leads an interdisciplinary lab focused on the design and implementation of novel HPV detection technologies to address cervical cancer disparities by meaningfully engaging underserved communities. Translational science, her lab employs participatory methodologies to increase adoption of technological innovation, empower community health workforces, and improve health outcomes for vulnerable populations. Dr. Rodriguez is the recipient of a Career Development Award from the National Cancer Institute and a 2023 NIH Director's New Innovator Award. Welcome, Dr. Rodriguez.
Thank you for having me. I'm thrilled to be here. Thank you so much to the organizers and to the American Cancer Society. I work in cervical cancer, which I'm thrilled to see is at least represented in the room. Was grateful to meet a few advocates earlier. And it's a really exciting time for cervical cancer screening because of recent developments globally and here in the US, although we are trailing behind, but we're getting there. So I'm thrilled to share some of those today, namely HPV self-sampling, which has garnered a lot of attention in the past year. And I'll share a little bit about our work trying to implement this new alternative screening method in an underserved population experiencing homelessness. We always say, we work in lots of different populations, but if we can do it in the homeless community, we can do it anywhere because this is such a uniquely vulnerable population that experiences all of the barriers to preventive healthcare and cancer screening. And so any success and lessons we learn here are widely applicable to other underscreened and underserved populations. So today, let's see here. Am I able to advance my slides? Sorry. Oh, there we go. Thank you. So today, and just to mention, I have no disclosures. This work is funded through the National Institutes of Health. I'll share a little bit about cervical cancer statistics here in the US, just to make sure we're all up to speed on where we are with this cancer. And I'll also talk about screening trends, because this is quite a public health concern in our country, as these trends have been declining pretty steadily. I'll introduce HPV self-sampling and where we are with that in terms of recent developments for cervical cancer screening, and then I will comment on or describe how we've implemented this strategy in a medically underserved setting and the lessons that we've learned from that, and some future directions for HPV self-sampling in the US based on those lessons. Okay, there seems to be a lag, I'm sorry. So cervical cancer here in the US, as many of you know, it's one of the few cancers that is almost entirely preventable and highly curable when detected early. We have a vaccine for it, which is the vaccine for human papillomavirus. Nearly all cases of cervical cancer are caused by persistent infection with HPV. And so we have this vaccine for it, and coupled with HPV vaccination, advances in screening have drastically reduced mortality rates globally as well as here in the US. However, we've really seen this progress stagnate. You can see here in this graph of about 15 to 20 years ago, we've basically flatlined in terms of seeing progress. And just this year, the American Cancer Society estimates we'll have over 13,000 new cases and over 4,000 deaths here in the US. So this also varies pretty dramatically regionally, and we see notable disparities both geographically. You can see on the left is incidence rates across states, and on the right is mortality. We certainly see some of those southern states really holding much of that burden. Iowa tracks pretty consistently with national standards and actually is doing a little bit better in terms of mortality rates. But when you look closely at different racial and ethnic groups, again, this is incidence on the left and mortality on the right, you see really notable disparities where Black, Hispanic, and American Indian, Alaska Native populations are far above national averages in terms of both incidence and mortality. When we look at cervical cancer screening, we know that early detection is key, as with almost all cancers. Localized survival rates are upwards of 90%, and almost less than 20% in distant states. And so, in distant stages, excuse me. And so despite what we know, we see this drastically reducing and declining cervical cancer screening rates. This is CDC data, and you see this upward trend up until about the year 2000, and screening rates have steadily declined since then. That blue line that you see is our Healthy People 2030 target, which we are nowhere near reaching, and in fact are getting further and further away from it, so much so that they continue to actually decrease that target to make it more attainable, which is kind of sad. And if you continue to look at this in more detail, you can see pretty profound disparities here as well. So this is quite small, so I'll just tell you, when we break this down by race and ethnicity, you see very similar screening rates, trends over time, but particularly after and during the pandemic, you see these steep declines among Black and Hispanic populations. Same if you look across education levels, same overall trends, but those with less than high school education consistently below these targets. And then same with income levels since about the year 2000, declining screening rates, but for those below 200% of the federal poverty line, consistently lower screening rates. So in terms of how we've screened for for cervical cancer in the US, our U.S. Preventative Services Task Force has continued to update these guidelines with new and available evidence. And so in 2012 was the first time that HPV testing was added to our national guidelines. Before that, it was Pap smear testing only. Since then, HPV was added as an option in addition to the Pap. And so this allowed intervals to increase. So you could either be screened with the Pap every 3 years or Pap with HPV testing every 5 years. In 2018, a new strategy called primary HPV testing was added, which is HPV testing alone without the need for a Pap smear. And this, if you're negative for HPV, don't need to be screened again for another 5 years. In 2024, just this past December, our USPSTF updated these guidelines again. They are still in draft form. They were open for public comment for about 6 months. I believe that period has now closed, and so these should be finalized later this year. But what this does now is indicate that HPV alone is the preferred strategy over the Pap and over Pap with HPV. And this also introduced the option for both clinician and patient collected samples. So not only do you not need the Pap for initial screening, you are now able to take your own vaginal swab sample, and this is based on decades of evidence, but is what many other countries are currently practicing, but is currently in this draft recommendation. This shift to primary HPV testing as the preferred option, it does align with current WHO guidelines as well as American Cancer Society guidelines. And it is, again, based on decades of consistent evidence that show us, first of all, HPV screening strategies detect more precancerous lesions than cytology alone. We've known that for many, many years now. And so this finally aligns with available evidence. We also know that there's very strong agreement between self-collected vaginal samples and physician-collected samples. And there have been numerous meta-analyses and randomized trials that have shown this concordance between a clinician-collected sample and a patient-collected sample. We also know in 40 of 42 trials reviewed by the U.S. Preventative Services Task Force, allowing for patient self-collection increased cervical cancer screening rates. It addresses many of the barriers that we see that keep populations from getting screened for cervical cancer. So let me explain a little bit about what it is now that you know it's finally being approved. This strategy just allows a patient to collect a vaginal swab, and that can be tested for HPV without a speculum exam. And so it does need to be run on an FDA-approved primary HPV screening platform, of which there are 3, the Roche Cobas BD on Clarity and Abbott Alinity. So it's the same platforms that are used for provider-collected specimens. This became FDA-approved for the first time in May of last year. And so this was specific to clinic settings. So it allowed patients who refuse a PAP or who are unable to get a PAP or a speculum-based exam to self-collect under the supervision of a clinical provider, so in a clinic setting. This then introduced the American Society for Cytopathology and ASCCP, they released guidelines to provide providers with guidance on how to incorporate HPV self-sampling into their clinic settings. This was released February of this year. And then, there we go. The first at-home self-sampler, this is called the Teal Wand, and it's this teal-colored one on the right. This was approved for the first time in May of this year. So just a few months ago. These are very, very recent developments, and things are happening very quickly here in the US. And as you can imagine, this is not being widely implemented yet. This is still very new, but the landscape is changing very quickly. The ACS has recently released clinician key messages to bring providers up to speed on the evidence and on best practices for implementing this in clinical practice. And if you scan this QR code, that'll take you directly to clinician key messages for providers. And they also have implementation steps, implementation webinars coming out just this month. So that's very exciting. And we have many clinical partners that are looking forward to these guidance and support in implementing these changes. And just to summarize, this provides yet another option for screening, but one that has potential to increase participation among specific groups that we know are lagging behind and we know are underscreened and have been historically. So this is people who, for whatever reason, do not want a speculum exam, and we know that this can vary widely for underlying reasons. There are cultural reasons, there are social reasons, there are many, but this is a growing population. LGBTQ communities, people with a history of sexual trauma, people with physical disabilities, and people with limited healthcare access. So we're thinking of rural settings. We're thinking of people experiencing homelessness and those who experience all kinds of barriers getting to the clinic. So this is the population that I work with, and it's where we have started implementing HPV self-sampling. So I'll share a little bit about that work and the lessons that we've learned and where I think HPV self-sampling has a lot of potential to really move the needle on cervical cancer here in our country. Just quick background. For those who may not be familiar, homelessness continues to be a growing and urgent public health crisis. We've had record high numbers in the previous years, particularly since the pandemic. And what we know is that this population is sicker by almost any metric. They die about 30 years earlier in terms of life expectancy than our national average, and often from preventable illnesses like cervical cancer. We have very, very limited data on cancer incidence and mortality in homeless populations, and this is because they're largely underrepresented from our national survey instruments like BRFIS and HINTS. And usually homelessness as a social determinant is not appropriately reported in clinical, in medical records. And so we have just such limited data. But what we do know from existing literature is that incidence and mortality rates for cervical cancer can be up to 4 times higher among people experiencing homelessness than national averages. They also have far lower screening rates. About the small studies that have been done, and primarily on the East and West Coast. There's been very little done in the Midwest with homeless populations. But those indicate around 50% or less screening coverage. We know they face all kinds of barriers to healthcare. There's the typical ones: financial barriers, literacy levels, transportation. But there's also unique vulnerabilities in these communities. They experience such high levels of stigma and discrimination that there's high reported rates of mistrust of healthcare providers, very high rates of sexual violence and trauma, and this can often lead to delays and refusals of PAP tests for women. There's also system and provider level barriers. We know that providers often have assumptions about homeless populations and their priorities. And so, they're looking for a place to sleep tonight, where their next meal is going to come from. And so do they really have the time and the wherewithal to think about cancer screening? But what we do know is there's been some small qualitative work done to show people experiencing homelessness are quite concerned about especially preventable illnesses and things that they can go on to get sick from later and put them in further financial burden. And we also know that this narrative about let's wait till they're housed is not beneficial in any way. There's often even less opportunity to intervene once these populations leave homeless shelters. They often experience recurrent and chronic homelessness, and even those who get rehoused are often still underemployed and underinsured and are not getting the preventive health care that they need. So if we can reach them where they are when they're still in seeking services in homeless shelters and homelessness service agencies, we're much better to set them up for success, much better off. And there's appropriate opportunity to intervene, and yet we don't have existing frameworks for how to reach them in homeless shelters and bring preventive care, bring cancer screening to them. So that's what my team has been working on in the case of cervical cancer in this population. I'll just share, a little bit about this study. This is an ongoing 5-year study addressing cervical cancer among people experiencing homelessness in Indiana. And this is at 2 major homelessness sites. And pardon my congestion. We are focused on an urban population in the capital in Indianapolis and also a rural population that's served at a continuum of care in Lafayette, Indiana. And we focused on women experiencing homelessness ages 30 to 65. And we have quite a few objectives for the study, and I'll just share some highlights with you today. But we are starting from scratch because we knew nothing in this community. So we wanted to understand their cervical cancer screening coverage. Are they getting screened? And if not, why not? Their risk factor prevalence, and also understand their attitudes and knowledge towards screening, identify barriers and facilitators to screening, and then finally use all of that to design an intervention. And so we are, I was glad to hear about promotoras earlier, community health workers. This is a community health worker-led intervention. We have them at both shelters. They are providing outreach, cervical cancer education. They offer HPV self-sampling, they have kits and informational materials about it, and they also offer navigation to healthcare providers for standard of care screening. And this is ongoing. I'm going to share some of the hot off the press findings with you, but what we're looking at understanding is this acceptable to this population, and what does that uptake look like of HPV self-sampling in shelters? Is it feasible for them to do it? So much of the pushback that we got is, well, are they going to be able to do it correctly? Is this actually going to be similar rates to what providers are able to do? How are you going to communicate the results to them? How are you going to make sure to get them follow-up care once, if they are HPV positive? And so all of these things is what we're trying to understand with this project. Kind of based on what we heard from the previous speaker, I just do want to speak a little bit to our approach. We do have a community advisory board in place that includes providers, homeless shelter staff, community health workers, and people with lived experience of homelessness who have guided all phases of the intervention design. And I agree with the speaker so much. This is so imperative to really have people's voices at that table and co-designing of that process. We conducted surveys at both shelters to understand people's screening coverage and their risk factors. We also did interviews with these populations, and we conducted a human-centered design workshop to really co-design that intervention and make sure not just the intervention and what we were offering was based on their own needs and priorities, but also the educational materials spoke to them, made sense, and the messaging was encouraging and tailored to their experience. And then we are implementing the intervention, so I'll share a little bit of that with you too. In terms of risk factor prevalence, these are just some of the common risk factors for cervical cancer, very high rates across the board in this population, and that was not at all surprising. But what I do want to share is some that were even worse than we could have imagined. Dr. King earlier this morning shared our national smoking prevalence is about 11%. Well, in this population, it's 73%. And I saw those numbers and thought there must be something wrong. Let's go back and check this. If you look at national literature across the US, this actually tracks almost identically in all homeless settings where people have surveyed smoking prevalence. It has been consistently around 70%. So this is just, now that we understand more about the context, it actually makes perfect sense. But this is just one example of so many risk factors where this population is just uniquely exposed and vulnerable. Very low levels of HPV vaccination rates, and high rates of sexual activity initiation before age 18, which is one of those risk factors for cervical cancer. Screening coverage tracked similarly to what we had seen in other populations. So our US average, 22% overdue. In Indiana, we're a little bit worse off. It's about 24% are overdue. In this population of people experiencing homelessness, about 45% are overdue for screening, with a small population having never been screened in their entire life, and with most of them not having been screened in the last 5 years. We did identify a few risk factors that were predictors for being overdue for screening. The one I want to highlight is duration of homelessness. The longer you are homeless, the more likely you are to not be screened in a timely manner. And so what we found is those who were homeless for more than 5 years were 2.6 times as likely to be overdue than those who had been homeless for less than a year. And that less than a year is something we look at commonly because HUD classifies over a year as chronic homelessness. And so we look at how long someone has been homeless over the course of their lifetime, and that tracks very closely with chances of being overdue. What we did learn, though, is they were all very willing to be screened. 84% in our survey said they wanted to be screened, believed it was important, and an additional 10% didn't really think it was important, but were still willing to do it. And so this narrative that they're not willing, they're not worried about this, is just not supported by our data. In terms of barriers, we see all of them, all of the typical reported barriers, so lack of transportation and insurance and no childcare, having to take time off work, fear of results in the procedure. But we also see unique barriers in this population. This is a quote from a participant. I've been in a homeless situation. It's hard when you're in survival mode, just trying to make ends meet every day, to go out and take the extra step to do anything for yourself or serve yourself at all. And in addition to those sort of compounding and competing priorities, there's also a lot of mistrust, as I spoke about earlier. And this is one that I really wanted to highlight. More than half of our participants, and we've spoken to over 200 women now, over half of them have experienced sexual assault in their lifetime. We know that this tracks with the literature, very high rates of both sex work, but also survival sex in this population. And 1 in 4 of our participants have reported being uncomfortable getting a Pap test because of their sexual assault history. And so this is a very big deal, and one where I think HPV self-sampling, or where we now know HPV self-sampling can really be quite a tool to our advantage. In terms of facilitators, a lot of the typical things that we hear: education and awareness, understanding of the procedure and the resources available, where can they get screened if they want to, reminders, and having outreach and support. So another participant quote, and we heard this in so many different ways, but I want to do it, I just don't even know where to start. And so what we learned in terms of all of this informed the intervention and also the education that we provided. So this is just some screenshots of the flip books our community health workers ended up using, where the participants saw a very simple sort of pictorial educational message, and on the back there was a lot more information the community health worker was able to provide about cervical cancer, about screening, about available resources, how to do it, where to do it. And then this is the intervention that we ended up, that is ongoing right now. So in the blue is where it starts. The community health worker provides education. And they tell people, they use the split book and they tell people all about cervical cancer and why screening is important and how to do it. They then offer options. So participants are able to get navigated to healthcare providers for standard of care screening. We have clinical partners, we have our Indiana Breast and Cervical Cancer program partners that provide free screening for uninsured women. So we have all of the pathways available to navigate folks if they want to see a healthcare provider. We also offer HPV self-sampling in the shelter. We use the Evelyn brush. It's a very common and well established tool, basically a giant Q-tip with a little brush on the end. We offer that. Participants are able to choose either, both, or none. So they can go to a provider and also self-sample if they're curious about it. They can just self-sample if they don't want to go to the doctor. Or they don't have to do anything, actually, after the education. This is entirely up to them. If they choose to self-sample, we ship that sample off to a lab for testing. We get results back within a week or two, and then the community health worker finds the person again to deliver their results and to navigate them to follow-up care if they need it. And so just, again, hot off the press, we're about halfway through our enrollment right now. We've enrolled about 191 women in this education. About 1 in 3 have chosen to self-sample, 32%. And that was very exciting because they have no reason, no incentive to do this other than their own wanting to know their HPV status. And that has been really great to see. Only about 13% have chosen navigation to healthcare providers. Again, we provide all of the support, outreach, navigation, and encouragement, but that is a very real barrier. And so it was promising to see this uptake of the self-sampling in the shelter, and it showed us we can really use tools and do more to bring healthcare to them for those especially who don't want to visit the clinic. One of the biggest concerns from many reviewers of this work previously was that will they be able to take their own sample correctly? And so far, out of the 62 women who have self-sampled, only 4 have had invalid results come back. So, the vast majority are able to do this correctly. It's not a hard thing to do, and we have the manufacturer's video and instructions that we show them, very similar to inserting a tampon and rotating and pulling it back out into the tube. So they've been able to do that well. We've seen about a 23% HPV positivity rate, which is quite high, but not surprising in this population. We've been able to communicate results to 63% of participants so far, and I just want to say this is very preliminary and ongoing. We will continue to reach out and try to find them for up to 6 months post-intervention. So this number will increase, but it is certainly not a given that we do find them again, and that is a real barrier in this population, but we've been able to show for the majority they're actively engaged and want to remain in touch with the community health worker to get their results. Of those who've tested positive for HPV, half have already been navigated to follow-up care, and again, we continue to work with them and continue to encourage them for up to 6 months post-intervention to seek that care if they need it. We've heard some really great feedback from the participants on the self-sampling, so we asked if they found it easy to use. 99% said yes. Do they feel like they were able to follow instructions correctly? And again, this is a 60-second video we show them, and then the community health worker is available to answer questions if they have it, but it's the manufacturer's video. It's very straightforward. Do you feel like did you feel comfortable using the self-sampler? 100% said yes. Did you experience any pain or discomfort using the self-sampler? About 1 in 5 women did experience some discomfort, and they've given us a lot of feedback on maybe providing better instructions on the angle of insertion, but most of these women had not used tampons before, and so we can see maybe where we can tailor some of those instructions, but for the vast majority, they did not experience pain or discomfort at all. Would you recommend using the self-sampler to other women? 99% said yes. And then, do you prefer the self-sampler method over the pap smear? 70% said yes. About 20% were unsure. They thought it was great, but also appreciated going to their healthcare provider for this, which is always what we encourage. And so that was interesting to hear about. About 10% did not prefer this over the pap smear. So what we've learned so far in this population, We know unique vulnerabilities, very high risk factor prevalence, and yet they are disproportionately underscreened by any measure for cervical cancer. But their barriers are modifiable. They're certainly unique and compounded, but they are modifiable, and these are not impossible challenges. The vast majority of this population, they do want to be screened. This narrative we hear about that they don't care about their health, they have bigger problems, it's just not supported by what we're seeing. HPV self-sampling has seemed quite promising so far, highly acceptable and feasible in this setting. We have healthcare providers and shelter staff and women with lived experience, again, on this community advisory board, and we are thinking long-term. How do we make this sustainable? How do we implement this in a way that can continue far beyond this research? And there are really feasible ways to do this, particularly when we have those clinical pathways solidified and those partners in place so we know where to navigate folks to care afterward. Certainly have experienced some challenges so far. So I mentioned it takes about a week or two to get results from the lab, and if we could shorten that window, I think that would improve our process quite a bit, because a lot can happen in a week or two in this population. People do get rehoused, people move to a different shelter, they're moving and bopping around, and it is an opportunity to lose folks to follow up. And so that has been a challenge that we're trying to address. For most participants, receiving a positive HPV test was a motivator for many to seek healthcare. It was that start of a conversation to say, okay, maybe I do need to go to the doctor. And this is what we want. We want to get them into care. But for some, they were still not willing. And so again, we continue to do that outreach and that education, and we will continue to do that for up to 6 months. But we can already see where for some, even receiving that test result is not enough to overcome the fear or mistrust. And then that's a real problem, because we know they have a positive HPV result. And so that's where our community health workers are really doubling down to try to navigate them into care. There was some confusion among patients who were then followed up with their healthcare provider, where they were hearing things from the provider like, oh, well, if you self-collected it, let's just do it again. And so there is some confusion about, well, isn't this now FDA approved? Isn't this something that, why are we sort of repeating the same test in a healthcare setting? There was some confusion, and that actually brings me to a really important point, which is about the future direction for HPV self-sampling in the US. Clinician buy-in is essential, and then that's pretty obvious. But what isn't obvious is what we need to get to that point. And I think clinician education and the right communication tools are going to be so important in this case. I mentioned the American Cancer Society has those clinician key messages, and they're working on these implementation guides and webinars. But we know that for both primary HPV testing and self-sampling, there is a lot of hesitation from providers. We've done this study in Indiana that showed, and I'll be brief about it, but this graph on the left is showing how providers are screening their patients. These are providers in Indiana. This was a statewide survey who conduct cervical cancer screening. Only 3% are doing primary HPV testing, which means HPV testing alone, no PAP. But what was even more concerning was when we asked about their knowledge, their awareness, their perceived benefit and willingness to adopt this method. About half, or 56%, we had a line straight from the clinical guidelines. Primary HPV testing is an effective cervical cancer screening method for asymptomatic women ages 30 to 65 of average risk. True or false? That is literally the first line in our current guidelines, and only about 56% of our clinicians answered that correctly. In terms of their awareness of it, we were surprised that folks were still not even aware that they did not need to conduct a PAP for asymptomatic average risk women. And willingness to adopt, only 50% were either willing or strongly willing to adopt primary HPV testing once presented with the evidence. So we have a long way to go in terms of buy-in just on the HPV testing alone, which is, that buy-in is essential for this self-sampling. When we then asked about self-sampling, less than half were willing to adopt this. And this provider kind of summarized so many of the concerns we heard. It's clearly better than nothing, but my concern is, where exactly are they sampling? Are they doing it correctly? Are they actually acquiring cervical cells? And are they going to come in for other necessary care? This got cut off here, but these were so many of the concerns we heard over and over again from providers. And so I think some of those messaging tools and communication tools with providers, first of all, need to include data on patient preferences. We know patients want this. There's been so much work in this area from myself and others that have shown from many different types of communities that this is something patients are interested in and want the option for. Patient educational materials are available that already emphasize the purpose of self-sampling and also the need for follow-up care. And we know that that receiving of that test can be a motivator to seek additional preventive healthcare and additional healthcare. So that's going to be an important message to include. We also were surprised by how many providers were concerned patients were not going to get an adequate sample. There's so much evidence to show that the contrary, and also all FDA-approved HPV tests report on sample adequacy. So for any sample we submit, whether it's patient-collected or clinician-collected, we will know whether there were cells present. And so a negative result does not mean invalid, right? We're able to differentiate that. And so those sample adequacy controls are key, and again, apparently something we need to include in that messaging to really get that point across. Another point that I just want to end on, I'll leave some time for questions. There's a lot of HPV self-sampling evidence that's building in the US, really awesome studies that have come out in the last month or two even, and the focus of them has really been on mailing kits. And so we've seen safety net hospital systems mailing HPV kits to patients who are eligible but overdue for screening, and have seen some promising results in terms of increase of cervical cancer screening participation. So fantastic work, and we need to continue and push that envelope even further. But that will not be enough to close our gaps in cervical cancer screening. Who are you going to mail these to for people who are homeless or unstably housed or transient or migrant, or for patients who are not yet patients, who do not have an address in your medical record system? So we really need to continue to think about strategies that do further outreach to participants. We can't just mail people kits. We have to do more than that. And some additional strategies I wanted to highlight, and again, is very new and the landscape is changing quickly, but we have EHR reminders in place in many safety net hospital systems, where if patients are eligible and overdue, they're flagged in the system. And so a strategy that's very, very promising that has been done in other countries is opportunistic offering of HPV self-sampling. So if patients are coming in and they're flagged as overdue, they're there for something else, primary care, they're sick, they're coming in for their flu vaccine, whatever it is, they are flagged and they are offered a kit to take with them or to do in the bathroom right on spot. And there's been very, very promising results using this strategy in terms of increasing rates. Doing the same thing in emergency departments might be an interesting strategy, especially since a lot of our most vulnerable populations, that's their primary source of healthcare is emergency rooms. So same thing is opportunistic offering of self-sampling. And then other countries have also started looking into pharmacy distribution models. So we get, I don't know how many of you have gotten a text from Walgreens or CVS saying, hey, we have our HPV vaccine is now available, it can prevent cancer. Doing something similar, but for HPV self-sampling kits where you can pick them up at your pharmacy and do that yourself. So it's a really exciting time for cervical cancer screening. I think there's a lot of opportunity for self-sampling to play a big role in closing these gaps. We just need to make sure that this innovation really leads to equity. So thank you for having me. I'm happy to take any questions, and this is my labs and my email address if you want to reach out. Thank you so much.
We have 2 online questions, but then I'll go to Georgia. So first, what is the cost of the teal wand, and is a prescription required?
So I know very little about the teal wand. Thank you for that question. Because it is so new, it was just approved a few months ago, and it is not actually commercially available yet. And the reason is that it has to be prescribed, and there has to be a component of telehealth afterwards. So you can sample at home and you ship it off to a lab, but there is that telehealth follow-up where a provider still tells you your results and navigates you to additional screening if needed. And so there is some, it will be piloted in California, but there is still some lag in terms of deployment. I don't know how much it costs. That's a good question. The Evelyn brush that we do use is about $2.50 per, and that's not at scale. So it could be much cheaper than that, I imagine.
Thank you. And then one more that you alluded to, but just to reiterate, do these racial disparities in incidence and mortality correlate with decreased vaccination rates for HPV?
That's a good question. So there's certainly disparities in HPV vaccination uptake by race and ethnicity. I don't know if there's declines in those rates among racial groups, and I don't have that data with me. My focus has been screening, but I can imagine we see similar disparities because of similar barriers to healthcare.
I have a kind of twofold question. For HPV, with the HPV testing and no longer wanting to do
PAP. Mm-hmm.
what happens if they, I was doing they had cervical cancer all related to HPV?
Yeah, so great question, and want to be very clear, this will never replace a pap smear altogether. The pap smear is an important tool to visualize the cervical cells and make sure that precancerous lesions are not present. But as a primary screening tool, this can replace the pap because if there's no presence of HPV, there is no etiologic agent for the cervical cancer. If you test positive for HPV, the next step is a pap smear. And so what you're doing is just triaging who needs a PAP, as opposed to, the population entirely getting a PAP as a first-rate screening tool. It is not necessary, and it's essentially over-screening is what we're seeing at this point. So yeah, so HPV is that primary screening tool.
Okay, and the other part I had was if a person were to do their own HPV testing and then go to the doctor and have it, would insurance cover both of them?
Great question. So ideally, you wouldn't have that situation because a provider would prescribe, would allow you to do the self-collection, and so they wouldn't do it again as an HPV test. What would then bill afterward if you needed follow-up screening is the pap smear separately. So that's why that clinician buy-in is essential, because we can't have people repeating the HPV test or the provider repeating the HPV test because they didn't trust the patient self-collection. Particularly with these tests that have the sample adequacy controls, we shouldn't be having to do that. So right now, HPV self-sampling is not universally covered by insurance because those guidelines are still in draft form. I'll mention Arizona and California Medicaid have just included patient self-collection in terms of Medicaid coverage, and we'll start seeing that expand, I hope. But yes, the idea is that you would not do this twice. Yeah. Great question.
We have time for one more question if anyone has one. That's okay if not.
I think we have an online question. What about mobile clinics and taking providers and staff into those areas and setting up a mobile clinic for a day?
That is such a great idea. We have been seeing a lot of success with that too, and this is also a tool that would allow for that. our county health department has a mobile clinic, mostly for vaccinations and for STI testing. Since they're already allowing for self-collection for STI testing, women are already taking vaginal swabs for STI. This would be a very minimal sort of burden in terms of addition, and is something we're exploring. I think mobile clinics will be a great resource for rural settings especially.
Let's give Dr.
you.
Rodriguez a round of applause.